Thank you for coming out on a cold night with football, which is infinitely more interesting and more compelling, to come and hear about HIV and malignancy. I guess, as a number of you will know, that I started out in oncology back in the 80s after I'd specialized. Tom Bothwell, who was in the head of medicine, asked me to stay on in hematology, and I had an interest in palliative care in those particular days. That's around about 84, 85, and for the next approximately 10 years worked in oncology. So part of me has an ongoing interest in the field, and certainly in HIV there is an ongoing need to know about HIV and malignancy. And tonight I want to, on the one hand, talk about HIV and malignancy, but I also want to maybe go back to those days. I remember in 1982 reading a New England Journal article by this man, Eric Castle, professor of family medicine at New York University. And the article in the New England Journal was just on this: the nature of suffering and the goals of medicine. And I'd done some theology over in England. I'd been out of medicine for some years, and then had decided to come back into medicine when I came back to this country. And the title, The Nature of Suffering and the Goals of Medicine, I found very intriguing. Quite recently, Eric Castle has now retired and brought out a book. And this evening, as I talk about malignancy, I want to dialogue with Professor Castle and with you guys, talking a bit about what does it mean to be a physician? What does it mean in this day and age in South Africa to be a clinician, a physician? And what does it mean to look after men and women who are very, very ill indeed, very sick indeed? Suffering is personal, and medicine is a personal profession. One doctor and one patient, each incomplete without the other. And what I can say to you is that now at almost 40 years of doing medicine, and I'm sure Prof. Settle, others in this room who've kind of given all your life to medicine, and others here, will know that in a way you build a relationship over the years with this group of people who become your patients. I want to talk about this young fellow, WT, 28-year-old Angolan man, diagnosed HIV positive way back in 2002, and saw doctors in Angola, had at that time a cough, shortness of breath, rash involving the groin, the genitals, the thigh, and wasn't really helped in Angola. Came down to Johannesburg, saw colleagues of ours, of mine, in this country, was put onto antiviral therapy, Combivir and Stockron efavirenz, but after a few weeks stopped because of nausea. What was done at that time by the doctors in Joburg was a biopsy of the lesions in his groin, and the diagnosis was Kaposi sarcoma. As you can see, it's not only in the groin, but it was on his face as well, and it was in fact all over his body. In November that year, he got referred to myself, and I was working private at that time. Chest pain, he was coughing up blood, had night sweats, rash, and a swelling in the groin, and that rash has been mentioned, and he was clearly depressed and frightened. At that particular time, he only spoke Portuguese, so we needed to use an interpreter to communicate. Came with his mother, and from time to time, I would have to phone. He would give me his phone, and I would phone his sister in London, and we would communicate via London and Johannesburg, telling him what was happening to him. You may not be able to see that too well with the bright lights, but the thigh, the scrotum, you'll see there are masses of tumor. The thigh area itself, and you can see these hard tumors that one's looking at. This is Kaposi sarcoma, the most common tumor in Africa today. The number one tumor of our HIV people in this, on this continent. And as I examined him, it was also clear that there were crackles in the lungs, there were wheezes, there was decreased breath sounds in addition. So there was more to this than met the eye. And indeed, again, if you look at that chest x-ray, you will see that there are multiple nodules in his lung. And he really had a stage 4 tumor, which was everywhere. He was slightly anemic, sputum kind of somewhat worrisome, squamous metaplasia, and as you can see, the chest x-ray findings. He continued on, we put him on to stavudine 3-TC, and I put him on to lopinavir, boosted lopinavir at that time, Kaletra, gave him Bactrim, cotrimoxazole, treated his thrush, treated the herpes of his genitals, and contacted one of my colleagues in oncology, and we started him on chemotherapy for clearly tumor everywhere. Dornaribicin, Bleo, and vincristine, and we would cycle him every 3 weeks. He lived in Angola, so it was a bit difficult, and indeed by January he was much worse, in respiratory distress, and there was a large pleural effusion. We did a thoracotomy, and on biopsy we confirmed Kaposi sarcoma in the lung. This is now 6 months later, in July of 2003, and you can see that he's in major trouble with bilateral fluid, pleural effusions in both lungs, and collapse of the right middle lobe with extensive involvement of those lungs. And in fact, around about that time when I was examining him, I recall as I examined him and listened to the lungs, he actually coughed up pink stuff that was clearly tumor coming out of the lung, which was actually quite frightening. This was disseminated KS, Kaposi sarcoma, and in fact a discussion again with the oncologist who was looking after. We put him onto paclitaxel. Quite expensive. The sister in London offered to pay for that, and clearly improved enormously with that. If I go back to the beginning, I think the CD4 was 17 right in the beginning, with a viral load of over 200,000. We gave him paclitaxel, cycled it about every month or so, every 6 weeks. And this is now the current data on this young fellow, alive and well, very good health. There are some residual scars of that tumor left in the groin area, thickening of the skin, but perfectly normal. And the chest perfectly clear. This is now 9 years, 9 years down the road. So this end-stage tumor can in fact be managed. Kaposi sarcoma can be managed, but it does require a bit of effort on our part as the physician and the patient as well. You can see the CD4 and the viral load remains undetectable. And the kind of message that we as physicians in this epidemic want others to hear is that this is an eminently treatable condition, even when you would give up hope and say, hey, this is not going to work. I think one needs to have a positive attitude. Chronically ill persons must arrive at the ultimate knowledge that it is not what they do that counts, but who they are. For some, it's difficult to conceive of what is left. If you look at that young man with his tumor all over his body, difficult to conceive of what is left when the self is defined apart from its roles. And as clinicians, as physicians in the epidemic, what we do is we grow people to value who they are. Who am I? And remember, and this kind of reminds me of my days as a medical resident, as a registrar up the hill in the Joburg Gin, or over in America as a consultant and with registrars under me. A well person is a patient who's not been completely worked up, isn't it? The healthy, and that's kind of what we teach our interns. You have to carry on doing investigations until you find something that we can label the patient with. The healthy are ill people who are unaware that they're ill. And it's our job as physicians to find their illness and give them a diagnosis. Well, what about some of that basic science? The basic science of oncology and cancer kind of goes back to the ancient Greeks, the early concept of a seed in soil. And I have a quote note here from Sidney Paget, one of the early founders of modern medicine. And this discussion of seed and soil. We understand that seed to be the gene, the DNA of the person. At one time we would have called it the cell. We understand that it's more than just a cell, it's actually the seed, the actual gene. And the microenvironment, the tissues, into which that particular gene lives. And the genes around that will impact on that particular DNA. And then more recently, a concept of the climate, of the other things, the immunity, and particularly in terms of HIV. Why do patients get tumor? Well, because the immune environment that they find themselves in permits that, together with chronic infections, such as the hepatitis viruses, human papillomavirus, and other chronic infections that will permit that. And the concept is that single cells that we start off with are impacted on through a number of conditions in the environment. Tissue damage, chronic infection, inflammation, all of that will promote tumor development in time. The cells that have been affected by their environment will produce chemicals that we call cytokines. Chemokines are chemicals that particularly will influence the immune cells, the neutrophils, lymphocytes, and the macrophages. And as you can see, that with that, chronic inflammation will occur as time goes on, damage to the gene, the DNA, the effects of control of cellular growth, P53, growth stimulation, hormones and chemicals and so on, all of those will be subverted to allow then for cells to be mass produced. So cancer really is caused by an alteration in our genes. In oncogenes, cancer genes particularly, in tumor suppressor genes that no longer, P53, no longer suppress the formation of cancer in our cells, and by changes in microRNA genes. And it's kind of to be seen as a long progression of genetic alterations. Each alteration as the years go by, as the months go by, imparting some change that ultimately culminates in the transformation of normal cells to cancer cells. And these tumors possess cytogenetically different clones which arise from that transformed cell and other transformed cells in the tissue via secondary and tertiary changes to the genes. That heterogeneity contributes to the differences in behavior. And one remembers certainly when I was doing oncology, where you'd have patients with, say, non-Hodgkin's lymphoma, and one would respond to your chemotherapy in this way, and another would respond in a totally different way. There's a heterogeneity within those tumors that affects their response to treatment. Apart from that original clone, its subclones, the tumor also contains stem cells, all of which results in a kind of panoply of genetic identities that makes our management and our treatment often so difficult because of those cascade of genetic identities. And this huge variation in the state of differentiation of those cancers. And if one were to look at what is happening in terms of the genetic alterations, that translocation of a cancer gene, an oncogene, gene that is responsible for formation of cancers are translocation to a region where it's no longer regulated, it's deregulated, and it is now in an area where growth can be enhanced. Just to be aware that the products of oncogenes, and I've labelled several there from this recent review, transcription factors, chromatin remodelers, growth factors, etc. Those form for us in this day and age a place where we can attach our therapy, where we can produce monoclonal antibodies, where we can actually address some of these genes and block their effects. And in modern oncology, and where oncology is going now, it's kind of trying to perfect where the defect lies and aiming with these new drugs at getting to that particular transcription factor or epidermal growth factor, etc., and actually blocking its effect. And using this together with traditional methods of controlling cancer. Well, what are the 6 hallmarks of cancer? Immortality, abnormal growth regulation, evasion of cell death, programmed cell death, sustained formation of blood vessels, and then invasion of local tissues and metastases. And what we know now is that the tumor itself creates a microenvironment for itself in distant sites, but it allows it to actually spread further. And one of the interesting things is that some of the receptors that tumor uses, in fact, are the very receptors, as some of you will know, that we use also in HIV. For instance, the CXCR4 receptor, as you know, is an entry receptor into the CD4 cell. And I think many of you are aware that when we block that receptor, one of the issues has been, will we promote changes in terms of the immune system, particularly with that, and result in overwhelming sepsis infections. Okay, I think I'm going to move straight on from tumor immunity just to another factor that is clearly important. In fact, let me move back to tumor immunity for a moment, just to remind you that the T cells are actively involved in control of HIV and in terms of tumors as well. So that when we have profound changes in the immune system of people, as occurs with HIV, that ability to control and to recognize tumors, in fact, is impaired in that particular process. Furthermore, we know that tumors are facilitated by an environment where there is inflammation. This is the terminal ileum of a rabbit infected with HIV. And what you're seeing, these are the HIV virus, and you're seeing below the surface of the epithelium. And these are M cells, which are microfold cells, specialized cells in the ileum, in you and I, as well as in other mammals. You'll see that right immediately below that is a lymphocyte, then there'll be macrophages. These are specialized parts of our intestine. And we know that with HIV infection, with C. clade virus, that within 2 or 3 weeks, the immune system of the gut, of the gastrointestinal tract, becomes a focus of that infection. And the concept is that what is happening is that the immune system is destroyed selectively, particularly, or damaged, particularly in the gastrointestinal tract. And as a result of that, there is translocation, there's ability of either proteins, antigens, whatever, from the lumen of the gut into the portal systemic circulation. And as a result of that, chronic ongoing inflammation occurs. And the data clearly suggests, and this is from biopsy of the gut and biopsy of the lymph nodes in young fellows who've been recently infected with HIV. And these are controls, and you can see very clearly that active molecules, CD8 cells, interleukin, MIP1 alpha, RANTES, various proteins that define inflammation are present very early on in HIV. And indeed, if you follow these patients through the course of the infection, they continue to have increased levels of these inflammatory markers. That becomes quite important in terms of the long-term effect of cancer in our patients. This is Castle. The physicians may remain objective, but as the sick are in bondage to them, so they too are in bondage to the sick. These provide their power and the source of personal reward and status. Physicians are furthermore bound to their patients in other ways, for it is from these they learn understanding and improve who they are and what they know. And maybe if one were to look at the way we practice medicine, if we don't do this, if we don't look at our patients and learn from our patients, we've lost a particular very, very important opportunity for you and I as physicians, clinicians, to grow. And that is what Castle is talking about, that healthcare, looking after the sick in itself, is an opportunity for you and for me to actually grow up. And when I hear of patients, of colleagues of mine seeing 50, 100 patients a day, 60 a day, there's no opportunity for that. Never can be. Well, let's look at cancer epidemiology in HIV. This is a graph that comes through from the Eurocida study, and you'll see that it follows a trend of the decrease of AIDS. You'll remember back in 1996, 98 or so, that AIDS itself decreased significantly. Now, these are conditions that are non-AIDS related. These are deaths related to non-AIDS diseases in Europe. And you'll see that they have tabulated a number of them, and non-AIDS cancers come through. And it is of interest that should follow. Clearly, the control of HIV with antiretroviral drugs has brought down the likelihood of dying with AIDS, but it has also decreased to some extent and influenced non-AIDS conditions. But nonetheless, in this day and age, and that's 2005, what these researchers are pointing to is that in Europe, where people would have been dying of AIDS before, there's a large number of them dying of non-AIDS conditions, infections, cancers, liver, cardiovascular, and others. And why do patients die from these unrelated? Well, we mentioned already that there's ongoing background immune activation, inflammatory cytokines, and a number of other issues. And those will influence the long-term outcomes, and we'll see that in a moment in terms of the epidemiology of cancer. AIDS-defining and non-AIDS-defining neoplasms were defined in these two groups back in 1993 by the World Health Organization and also by the Centers for Disease Control. So by definition, this group are what we call AIDS-defining. This is non-AIDS-defining, although that difference in this day and age is probably purely semantic. If we look, and this is data from Freddie Cetus, who is now in Australia, used to work here in Joburg, looking overall at cancers in Africa. You'll see, and this is worldwide, he's comparing worldwide deaths in 2002 with deaths in Africa. And infectious causes dominate in Africa. One of the points that I want you to know is that, and what Freddie is saying here, 28% of the worldwide population is under 15, whereas in Africa it's 41%. So the demographics is very different worldwide and here, and particularly when in yellow you look at cancer. And in fact, if you look at worldwide, cancer is a major killer. But remember that these are older people, and that in Africa we're looking at younger people, and particularly when we look at HIV, we're looking at 20, 30-year-olds. And if we look at the major cancers in Africa by gender, female and male, these are the 5 most common. In men, it's Kaposi sarcoma. In women, quite important, Kaposi comes in at 3, after breast and after cervix. Cervical cancer, the most common in our women in Africa. This was data that came through a year or 2 ago from Laura Stain and from Margaret Urban, also here in the NHLS, here in Joburg, and looking specifically at HIV. What is the picture like in our HIV patients? Well, when they looked at their registry, they looked at about 8,000 patients, and they looked at the overall seroprevalence was about 10%, a little bit more in women, and in the group of people that they had in their registry, cervix, breast, and women, number 1, esophagus, prostate, and those were the tumours seen in the men and women per gender in South Africa. This was not HIV per se. When we come in their study to the HIV context, you'll see, and the numbers are fairly robust and fairly good, Kaposi sarcoma, in terms of HIV positivity, the number 1. About 89% of all Kaposi sarcomas in South Africa are in HIV positive people. Non-Hodgkin's lymphoma, 44%, anogenital, excluding cervix, 22%, and these are in the teens and early 20s down below. But important to note that those are the tumours, and anogenital, important, and one that we don't pick up very frequently, but very related to HIV, common in terms of HIV. And some of the comments that Margaret and Laura make in their article, Kaposi sarcoma comprised about 40% of all cancers in KZN at that time period, in 2001, 2002. But if they look back about 40 years ago, it is only 0.4%. So a very significant change has occurred over this time. 5-fold increase in non-Hodgkin's lymphomas in the HIV, and particularly 100-fold in those who are Burkitt's, HIV specifically in that group. And then an association likewise demonstrated between carcinoma of the skin, squamous CA of the skin, and one of the points they make, Kaposi sarcoma, the risk of developing was about 50-fold higher. 6-fold higher for non-Hodgkin's, 1 to 2.5 times higher for cervical, anogenital, and squamous for HIV positive patients in our particular part of the world. And maybe just as a backdrop to that is, again, work from Fred Saitis, just looking at the resources in Africa. If, for instance, you look at the DRC, where they have 55.9 million people, they have 1 radiotherapy machine, 1 oncology center for that entire nation. You can see South Africa and Egypt reasonably well counted for, but these other countries around us, pitiful. So that if you have cancer in those countries, your likelihood of being diagnosed is minimal. Your possibility of being managed and treated is near nil, unless you can get out of there and go to Egypt or come down to South Africa. And that kind of gives us a context which tells us that the situation in Africa is truly appalling and frightening. Sick persons are people who are forced to trust Castle again. But while the tools of modern medicine are largely technical, these tools and the power given to them must be wielded by people. Technology itself has no power. The huge power invested in the machinery of healing lies in the hands of people. And I guess if we look at where we're going in HIV management in this country, yes, technology, we have the drugs, we have all the rest of it, but the impedance to actually controlling, managing, is in the hands of people. Either those who are not aware of their status or those who don't come into treatment. This was the Aquitaine study from France, came through a year or so ago, just last year, looking again at the incidence of non-AIDS defining malignancies, finding that that is 2 to 3 times in HIV that of the general population. And indeed, we will see that in our country, if we aren't seeing it already. And malignancies, whether AIDS defining or not, have become, in this part of the world, France, the most frequent cause of death. And if we look, certainly the AIDS-defining non-Hodgkin's, Kaposi's, and cervical are in a major grouping, 107. But here, 144 are cancers that are not AIDS-defining, and yet are very important and life-threatening in the HIV population. Lung and skin again, bronchopulmonary, and so on. And from this data in France, emerges 2 very important points. One, the AIDS-defining cancers, the lymphomas, the Kaposi's, are associated with low CD4 counts, below 200 particularly, and with viral loads greater than 500 copies. Okay. Strongly independently associated with a higher risk. So in other words, when our patients come into care, as they do in Africa and South Africa in particular, with CD4 counts below 100, they have put themselves into this category, or where their viral loads are particularly high. They put themselves at risk for developing AIDS-related cancers. On the other hand, the non-AIDS related tumors down here, the risk of developing those is far higher. CD4s of less than 500. So in point of fact, when we look at starting patients, our patients, and we start them, as you know, in South Africa, at CD4s below 200, unless you're pregnant or have TB. But what the French are telling us, that, and they're saying that the major cause of death in their HIV is cancer. But they're saying that, hey, if you don't look at those with higher CD4s, of below 500, then you will miss a certain group of those who have cancers that are non-AIDS defining. And HIV replication, i.e. that high viral load, as both current today and cumulative over the last 10 years or 5 years that I've been infected, that cumulative HIV replication viral load is important in terms of the AIDS-defining malignancies, and has a major impact, particularly in the non-Hodgkin's lymphomas. So in terms of lymphomas, which are important, it is that allowing patients to maintain a high viral load chronically over time that flogs the potential to develop those lymphomas in these patients. And one of the points they make in their discussion is that early control of viral replication and maintenance of high CD4s, not allowing the CD4 to go low, is important if you want to lower the risk of malignancy in HIV. And data from a cascade study some years ago now will show you very clearly, as you look at the graph, that as you get down to CD4 counts that are below 200 or 100, your risk of non-Hodgkin's increases enormously. But you'll notice that that graph starts moving upwards even at 500. And that's an important note for us to remember and be aware of. The Arcona study is an Italian study, and that's come out quite recently. Says much the same kind of thing. What I want you to maybe note, and again, fairly robust, 6,000 patients, 51% hepatitis C virus positive. Considerable. And you know that the hepatitis virus is B and C, important in terms of liver cancers. AIDS defining, non-AIDS defining, both in France and now in Italy, they're picking up large numbers of both AIDS and non-AIDS defining malignancies. And again, the point that this graph of theirs makes very clearly is that below my CD4, and this is below 50, that's 50 to 200, and in yellow is the AIDS defining, and blue the non-AIDS defining, there is an increased risk. But you will see that as we get to higher CD4s, that risk decreases. So part of our job as clinicians in this epidemic is and should be to keep our patients up there as far as we're able, if we're going to do something about tumour. They found in this particular study a low current CD4 Kaposi in men who had sex with men, and interruptions, unreliable antiretroviral, older age were associated with malignancy. Quote from Castle's book again: life's presence is manifest to the senses, yet ever eludes the reach of our comprehension. We see life in someone running, stopping, looking back, but in the end the mystery persists. Say that a living person possesses a soul or a spirit or vital breath, and we have only invented names for ignorance. And there's a time with patients that there's something there which is kind of not tangible, that we can't touch. But that is why we value people in medicine, because there's something there that isn't defined entirely by our science. And that's what Castle is saying. The Greg Robbins' data, I think I've shown a number of you this before, but again says a very, very important point. And maybe I should quickly mention this again. What Prof. Robbins and his group at Harvard did, they went back and looked over about a 10-year period, although in this particular study they only look at 3 years, at patients put on ARVs. And they classified them, broke them into categories: CD4s below 50, 50 to 200, 2 to 350, up to 500, above 500. And they looked at not only the kind of adaptive immune system, the B cells, the antibodies, and the T cells, but they also looked at the NK cells, they looked at the innate. In other words, they did a very good, thorough job of looking at the immune system. And what Robbins shows in his paper is that for all of these people starting ARVs, the lower you start, 50, below 200, below 350, 500, you suckle to get up to, and this grey bar is the normal for whatever it is, whether it's this adaptive immunity, innate and so on. To get up there, you suckle. And the lower you start, the more unlikely you are ever to get to normality. And that becomes important when we talk about tumour and cancer in terms of HIV. And as I say, he goes through all of those and pointing to this situation of bacterial translocation in the gut as being one of the factors that plays a role in all of this. So we're dealing with people, real people. Trust in others is one of the central human solutions to the paralysis of unbearable uncertainty. Castle. And it's that trust that he's pointing to, and you and I in the epidemic of HIV and managing people, that's what they put in you and I. And that's kind of, again, what this epidemic calls for, people who are reliable. You and I who practice our medicine, our nursing, our health care, so that people can truly trust in us. Chronic pain is called wordless by some commentators, but I take it to be rather cry in a foreign language. Such pain is a sign, an icon opening a file, like on your computer, full of sorrow. To treat chronic pain with painkillers is sometimes to make mistakes in translation, because I don't know what the pain is really all about. and pills are not what is needed. I want to talk in the last kind of 20 minutes because I can't deal with every cancer, but I want to particularly look at Kaposi sarcoma because it's our number one. It's the kind of tumor I see a fair bit of KS and a fair bit of non-Hodgkin's in our practices. And just to say to you that it's mutilating, as you can see from a mile off. This is a tumor that is gross and it's mutilating and it's frightening to have it. It takes its name from Morris Kaposi, who started out as Morris Cohen, really. But in order to marry this young woman, he had to change both his religion and his name. And he was born in this particular town in Hungary. And the river kind of gave him his name. So when we diagnose someone with Kaposi sarcoma, we're going back 100 years, back to 1872, maybe 150, 130 years, to this Hungarian dermatologist who described in 5 men Kaposi sarcoma. We now know that it's a multicentric tumor. It's a tumor really of endothelial cells, cells of our vessels. And these are endothelial-derived spindle cells that we'll see in a moment. And these, we now know, are infected with a virus, which we call human herpes virus 8, or the Kaposi sarcoma associated virus. And we found genes in these cells that code for important receptors on the surface of the epithelial cells. And we've kind of established very clearly that this is a chronic infection, and a chronic infection that leads to cancer. Signaling to this particular receptor, chemokine receptor, results in activation of growth-inducing signaling molecules and the production of angiogenic factors. And its expression in the mouse model leads to formation. These are the KS viruses. They are DNA viruses, envelope viruses, as you can see, and they belong obviously to the herpes group. We now know we can map the genome. We have mapped the genome. We know its size. We know how many genes it contains, and we know the open reading frames and the different areas of that particular virus very well. Very important because in terms of looking at vaccines, and people are looking at vaccines against this particular infection, one needs to obviously know these things. And what we know is that it requires a receptor to get into the endothelial cells, and in fact that there's this particular XCT receptor, so-called, which allows it to transport the virus into the cytoplasm of endothelial cells. So the receptors that are important have been recognized. And this diagram is really a bit too complicated, so all I want you to notice is that the virus not only gets into the endothelial cell, but it also gets into immune cells, such as our B cells, our antibody cells, and it gets into T cells. And furthermore, it interacts, you can see with natural killer NK cells, it interacts with the innate immune system. This is the virus taken into the nucleus, and then various peptides of the virus expressed on the surface so that there is an interaction with T cells. The point about this is that once one has HIV, once one has HHV8 itself, that has a profound effect upon suppressing the immune system. And it does that through direct involvement with receptors on T cells. And it shifts that cytokine shift from a Th1 to a Th2 antibodies, and it blocks both macrophage function and also T cell function. So having human herpes virus 8 in one already has an effect upon the immune system. And then if we were to add in HIV on top of that, you can now understand why some people develop their gross Kaposi sarcoma at very high levels of CD4. because the underlying defects are already occurring at profound levels in the innate and the adaptive immune systems, even before HIV comes on board. And as I've said, we move to a Th2 system. Human herpes virus 8 has not only been described in Kaposi sarcoma, but there are other tumors, primary effusion lymphoma, Castleman's, and bone marrow failure, where it's been associated. And again, there are a number of forms. I'm only going to talk about the epidemic form, which is the HIV related, but there are classical, there are endemic, Central Africa, iatrogenic transplant forms of the disease, all of which are associated with human herpes virus 8. And again, to remind you that this is a mutilating, horrible, truly horrible disease. These are pictures of a man with classical, an older man with classical Kaposi sarcoma, not related to HIV. And when I was practicing oncology some 15 plus years ago, we had patients like this in Johannesburg, and I'm sure we still do, have folk who are HV8 infected, but are not HIV infected. So the tumor itself can affect the immune system and in time manifest on its own. Prevalence of antibodies in our populations, North America, the Middle East, and the Caribbean, and then in Africa, very high in our part of the world compared to the rest of the world. And in fact, if you were to look at North Africa and Southern Africa, Sub-Saharan Africa, 39,500 cases in 2002, 17,000 in females. At the same time, only 102 in North Africa. So kind of giving you a sense of the major impact that this has on our part of Africa. And please forgive those cats that have either got some electricity going through their spinal cord, I think. Zimbabwe, PCRs, 56%, 34% of vaginal fluid, 37% oral fluid. So when we look at the epidemiology of this virus, certainly in the blood, but also sexual genital fluids and oral fluids as well, and quite high levels. These are cross-sectional studies. Zambia, around about 48%. So a virus which has a high prevalence in our communities. These are blood transfusion recipients in Uganda, and the point in this particular study was about 10% of those who were exposed got the virus, but the risk was much less after 4 days or so. Okay. So again, blood can transmit. In Thailand, smaller percentage, 24%. Overall prevalence rates, again, important in this particular study. Overall rate was 30% in oropharyngeal, particularly. Well, signs, the clinical signs, and you've seen, I'm sure many of you have seen pictures of Kaposi sarcoma, lymph node enlargement with edema, as you've seen demonstrated in this man's face, visceral organ involvement throughout the body. And these slides show you very clearly oral lesion on the face, and it predominates on the face around the genitals and on the thighs, as you're seeing. This particular patient of mine was vomiting up blood, and when we look down, as you can see, we're going past the lower end of the esophagus. We're now in the stomach itself, and we begin to find loads of tumor in the stomach in this young person. On the nose itself, here this young fellow, one of my patients from many years ago, covered in Kaposi sarcoma. This young fellow with tumor in the mouth, now spreading up into that maxillary sinus. Again, tumor in the mouth. This patient, the foot almost destroyed with Kaposi sarcoma. A cecal lesion, and again, lung involvement. When we look at the histopathology of it, you may not see it in this light so well, but in this region there are multiple slit-like areas which are minor vessels, and the cells that make up the wall of those vessels are endothelial spindle cells containing virus. Here they have here they've stained with monoclonal antibody and stain, and all of this brown stuff is picking up virus within that tissue. The other important thing to remember is the immune reconstitution syndrome. When we put these patients onto ARVs, as you're seeing with this young fellow here who was put onto ARVs, in fact, edema, the face swells up significantly some weeks, about 2 weeks or so after, together with control of the HIV virus and control of the human herpes virus. So iris becomes an important part of managing these patients when we put them onto antiretroviral therapy. So in terms of managing antiretrovirals, the mainstay, the kind of bottom line of therapy, and then if it's fairly minor, local injections with chemotherapy. Certainly in patients with facial lesions, I would inject those lesions with vincristine into the skin, and often you'd see within a month or so that the lesion has disappeared almost completely, and with antiretrovirals in time, the lesion will disappear completely. Alpha interferon radiotherapy to large lymph nodes, obstructing lymph nodes, like with that young fellow with that tumor in his groin. One would control that brawny edema with radiation to the groin area. And then with disseminated disease, a number of drugs available to us, as well as highly active antiviral therapy. Two other conditions with human herpes virus 8, primary fusion lymphomas. This is you seeing a pericardium covered by fluid, and in the fluid are lymphocytes, and in these lymphocytes is human herpes virus 8. This is a multicentric Castleman's with multiple nodules you're seeing there, and the infiltration of malignant lymphocytes. I'm going to kind of end here. I'm not going to go through all the other tumors because we'll be here until tomorrow, and we can maybe do that at some other stage. I'm going to end with, again, with Eric Castle. What defines a good physician? The most skilled of practitioners raises the relationship with the patient to an art. And I remember when I was a younger physician and doing rounds with Harry.
You're still young.
When I was a younger physician, Harry. Doing rounds with Harry. Doing rounds with Tom Bothwell. That you would take people like that to a bedside and you would begin to talk. You were the younger registrar or whatever, and you'd tell Harry or Tom Bothwell a few words about the patient, and they would smirk or grin or whatever, and they would tell you typhoid or whatever, and walk on to the next bed. Physicians like that have, and I used to say, they had an ability to smell the disease. You'd take them to the bedside, within 30 seconds, they knew the territory. They knew the diagnosis, and you moved on. For them, looking after sick people had become an art, because they'd done their science, they'd seen hundreds over years. So that, as you mentioned, one or two critical factors, they got to the diagnosis almost instantly. They smelt the disease. Castle, not merely encouraging its growth and promoting trust and faith on the part of a patient, but negotiating the path between intimacy, kind of being a friend, allowing that trust to develop with the patient, and separateness. You don't jump into bed with your patient. Most of us don't. Between empathy, understanding, walking in the shoes of the patient, and being objective. Thank you very much.